Thanks, Rash. That was a lovely introduction. Can you guys hear me in the back? Great, thank you. So I am just thrilled to be here. I have to start by saying it's so much nicer here than it is in Boston and New York in the spring. I might just want to stay. And I'm very pleased to be here to talk to you about patient-reported outcomes in surgery and how we can use these different ways of looking at outcomes to improve clinical care and quality. I'm hearing a bit of an echo, but you guys are okay? Yeah? Great. So my disclosures, I'm a developer of the BreastQ and BodyQ and receive royalties when they're used in for-profit and industry-sponsored trials. There's no charge for use of these measures in clinical care or non-for-profit research or grant-sponsored research. So traditionally when we've looked at our outcomes in surgery, we've looked primarily at the clinician's perspective. So this is things like our morbidity, mortality, our complications data. But increasingly in surgery, we're aware of the importance of the patient's perspective. So why is this? Well, historically, just about everything we did in surgery was with the goal of saving a life. So in this situation, the patient's perspective is neither required nor relevant. This is about saving a life. So we still save a lot of lives, but increasingly in surgery, we're also very much concerned about improving the quality of patients' lives. So many of the procedures that we do now are about improving patient quality of life or restoring or at least maintaining that. So, so in orthopedics, all the big joint replacements, about improving function. Neurosurgery, back surgery, about decreasing pain, my own area in breast reconstruction, restoring body image, and then even in areas where perhaps the goal is not to improve, is to improve quality of life, but at least to maintain it. So say prostatectomy surgery, trying to maintain erectile function or continence. So there really has been a shift, and it's a part of the evolution of surgery, of what we're actually doing, and hence there's an evolution in terms of the outcomes that are relevant. So why do patient-reported outcomes matter? This is a quote from Andrew Vallance-Owen. I think if I put that there, it'll be better. Andrew Vallance-Owen, who spearheaded much of the work in the United Kingdom around patient-reported outcomes, and he says, for patients, there must be more to success than alive or dead, complications or no complications. How often have we heard, they said my hip replacement went well, but now I'm housebound. Or I have good flow in my bypass graft, but I still get pain after 10 meters. There has to be more to success than alive or dead, complications, no complications. And that's really the new world of surgery, that the bar has been raised on outcome measurement, and that's what patient-reported outcome measurement, that's where that fits in. So what are patient-reported outcomes? So patient-reported outcomes are those things that only patients can know and tell us about. So things that I can't know just by looking at you. So I think of patient-reported outcomes in sort of three main areas, or patient-reported data. So symptoms, so pain, nausea, these are things that we can only know if we ask our patients. I can't know just by looking at you. Quality of life, so as we talked about, so physical function, body image, these are aspects of quality of life, sexual well-being. And then also we're increasingly aware of the importance of patient experience and how that plays into healthcare. So we measure patient-reported outcomes with specially designed measurement tools called patient-reported outcome measurements, or PROMs. Now, PROMs are questionnaires, but they're not questionnaires the way we would traditionally think of them. So think of them instead as specially designed measurement tools that are precisely calibrated to measure very specific outcomes. So think of them more in terms of the way you might think of, in clinical care, any of the other things you would use to measure like blood pressure or hemoglobin or O2 sats. Or in research, if you were doing in your research lab, what would be the things that you might use to make different measurements in a study that you're doing in the lab? There's been a very significant change in the past about 10 years. Last 10 years, there's been a real paradigm shift in the way these questionnaires have been developed. So they traditionally were not valid in the way I've just described, but in the last 10 years, there's been a very significant change both in how we qualitatively develop questionnaires, so we ensure that they really resonate with patient voice, and how we quantify, or the psychometrics of it, or the way we would think about statistics, but it's the statistics of these questionnaires that has really changed, such that we can now really have this precise, reliable, well-calibrated measurement. So today what I'd like to talk to you about is all the different ways that I think patient-reported outcome measurement can be helpful to us in surgery. So we're just going to kind of walk through these different spheres. The first being clinical care. So how do we use patient-reported outcome data to actually do a better job looking after patients, to identify potentially unmet needs? Quality. How do we identify the things that matter most to patients in terms of both our outcomes and our processes to maintain and improve those things and benchmark? Value. We're in an increasingly tight healthcare situation in terms of costs. How do we make sure that our resources are really being directed to things that matter most to patients, and then perhaps also identify areas that don't matter so much and that are areas that we can actually, that potentially we can save healthcare dollars. And then finally, comparative effectiveness. So all the things that are new, how do we know what's actually, how do we differentiate new from new and actually better from a patient perspective? And how do we also identify, I think, some of the potential benefits of our treatments, of our surgeries, and also some of perhaps the hidden morbidities that we were maybe not aware of. And I'll show you some examples of that. So starting first with clinical care. So I'm just going to use, as Arash mentioned, so I'm going to use the BreastQ as the example for clinical care. So the BreastQ is a patient-reported outcome measure that we developed. It's condition-specific. We developed it specifically for breast surgery, and in this situation, I'm going to talk about its use in breast reconstruction. Just to give you a bit of a sense of the scope of this project, we developed the BreastQ. It was funded by the Plastic Surgery Foundation. We had help from over 2,000 women. It took us several years to develop the measure, and it's since had quite tremendous uptake actually now, and it's been translated and linguistically validated in over 30 languages. It's part of ICHOM standard order set, and we've had over 1,000 licenses signed by academic researchers and clinicians that are using it around the world, which is really fun to see in terms of all the different ways that it's being used. So by just a little bit of background about the BreastQ, just more to help you understand this example in clinical care. So this is a conceptual framework for the BreastQ. So the BreastQ measures all these different things. And blue is quality of life, green is satisfaction. I didn't do that to match my dress, but so call it physical well-being, psychosocial and sexual well-being, and then satisfaction of the breast outcome and care. And so each of these has a scale. So just to get the terminology of these things, so this is the conceptual framework, these are the domains, and then with each of these we have a scale. And a scale, which I'll show you an example, is that what I would point out is there's no overall BreastQ score, because we wouldn't want some composite score that means that people who have completely, great physical function, poor satisfaction of breast could look the same as the opposite, poor physical function and poor satisfaction of breast, the other way around. So each is an independently functioning scale. And so just as an example of what a scale looks like, so taking the example of satisfaction with breast, and what I'm telling you also applies to other patient-reported outcome measures. There's language around scales and items. This would be the scale, and each of these questions we call the item. And so in our work, we developed, we actually do everything electronically now, but I'm just showing the paper version to give you a sense of it. So we developed the BreastQ using something called RASH, similar to item response theory. And so these questions are actually on a continuum. And they range on a continuum from so this question, how do you look in the mirror clothed, to the softness of the breast, to how you look in the mirror unclothed. And actually this continuum was based on how the 2,000 patients in our sample described, as we were testing this questionnaire in that sample, they essentially, mathematically, they put it in this order. And really what it gets to, so if you imagine, if I have kind of my worst reconstruction, or maybe no reconstruction, maybe she has a prosthesis, women can still be very happy with how they look in the mirror clothed. But it's only my really best reconstructions that a woman will tell me that she's actually happy with how she looks naked in front of the mirror. So how patients answer these questions sums to a 0 to 100 number, and that number and extending from here to there effectively. And so it's not a % satisfaction, it's a 0 to 100, but effectively then these questions or these items become notches in what we call the RASH ruler. And so this is to give you just a bit of a sense of how these questionnaires really are measurement tools, and I'll show you a little bit how this RASH ruler also helps us to interpret the data so that we can understand the clinical meaning of the numbers. So just going back a little bit to how we use the BreastQ in clinical care. So we did this in collaboration with our breast surgeon colleagues, and so across all of MSK, and here I'm speaking of my MSK experience. I only just got to Boston about a month ago. So we talk about across all of breast surgery, so not just reconstruction. So women have lumpectomies and radiation, or mastectomy reconstruction. Patients are asked to participate in this, but it's part of clinical care. They're not introduced to this as if it's a research study. It's part of how our team is looking after you. And so patients complete the BreastQ before surgery and then also after. And so I'm just going to give you an example here of what, so this would be a BreastQ report. So on the y-axis is 0 to 100. This is physical well-being, chest and upper body, and a higher number meaning better function or a better quality of life. Here's preoperatively, and here is at post. So this is a patient at a tissue expander place. So for the non-breast surgeons, a tissue expander is essentially a device that we put subpectorally, and it'll later stretch up the muscle. So it's quite a decent dissection, and it's uncomfortable. So here's a patient 2 weeks after, and here she's gradually coming up. So what happens practically in our clinics at Memorial is patients, this is looked at by the nurses, and they will identify this is a patient at this time point who might benefit from physical therapy, pain management, other things that we can offer. And you can imagine the same sort of thing if it was a patient looking at psychosocial or sexual well-being. We could offer referrals to different services or identify that unmet need. Another example, this is a patient of mine. This is satisfaction with breast, psychosocial well-being, and sexual well-being, and these are all the graphics. So every time I walk in to see a patient, this is what I would see on that patient, and she might have just done it on an iPad in the waiting area, but it's sort of instantaneously uploaded and scored to refresh essentially her report. So this is a patient of mine. She's had a tissue expander and so she had implant breast reconstruction. So this is kind of every 6 months. This is 2014, twice in 2015, twice in 2016, and 2017. So you just learned, many of you just learned about the BreastQ, and you've never seen my patient, but you can tell just by looking at this that something's is not okay. But interestingly, I actually couldn't. So this is a patient of mine. She was a really lovely woman, never complained about anything, and I had been walking in to see her at these different time points, and she looked pretty good. And I said, how are you? And she would say, I'm fine, which is what a lot of patients will say if you just say with your hand on the door, how are you? And is everything, or you'll say actually, everything good? Meaning you should probably agree with me. Anyhow, so this is just, this is a very true story, is I hadn't seen this report, and I walked back in, I looked at this report again, and I did a double take thinking, is the data wrong or something? And what it was is she'd had implant reconstruction, and bilateral, and she had what we call capsular contracture that had been slowly developing on one side, which had been gradually making the one breast feel firmer, which I appreciated, but I went like, it doesn't seem to bother her. But it was because it was like me assessing whether it really bothered her or not, and it really did bother her. And I had to give her permission to sort of say, hey, let's talk about this, because she didn't want to bother me with it either. And so anyhow, she ended up having her implant removed and replaced, and but to identify that this was a need that I completely missed, and that we can use these measures in clinical care to improve how we talk to patients and the services that we offer them. So I'm going to show you an example of a different way of doing things, which I just sort of, this is a group from Utah, and this is not a criticism of the group in Utah. They do fabulous work in patient-reported outcomes. But, so I just showed you the BreastQ, and so again, you're not seeing my patient, but you can see the report, you can see clinically what's going on. So the BreastQ is what we call a condition-specific measure, so it's very calibrated to exactly what to the issues of breast surgery patients. This is more generic measurement, so this is the PROMIS item bank. So this is a patient who had bariatric surgery around this time point. And you can see that sort of nothing is really changing as far as what the PROs are telling us. And it's because we're asking quite broad, generic questions that aren't specifically targeted to the patient population. And so, this isn't really compelling for a physician to take a look at, because it's kind of not telling me something that's super helpful. Because it's not telling me that anything's going on, when actually something could be going on, and it's just the way we're asking very kind of broad-based questions. And I say it only because if you are thinking about setting up these kinds of systems, there's some easy things that sort of make it more successful. Another example, so this is, again, not a criticism at all, but just, so the PROMIS measures kind of go in different directions. So this is a patient that's actually doing better, and what you see, so basically here is pain interference is going down, and physical function is going up, but the curves are going different directions. So in terms of understanding it at a glance, some stuff, sometimes good is down and sometimes good is up. And so as a clinician, we're used to looking at vital signs. It has to be cognitively, we have to be able to understand it the way we would look at sort of essentially the new vital sign that we're looking at. So there's certain things, and this is part of as we evolve in terms of using patient-reported outcomes in clinical care, we're all kind of talking and we're all getting better at understanding what works and what might work better. So the thing that's also kind of exciting right now is that, so when we started developing all these measures and thinking about what patients could tell us, it was at a time paper and pencil was the thing. And kind of coincidentally, all of the information technology age where we do everything on our phones and everybody's filling out a survey just kind of happened to be happening at the same time. So what we have now is these super cool new patient-reported outcome measures that can do things that the previous generation of patient-reported outcome measures couldn't do. And we also have the fact that we have everybody's doing things on their phone. Everybody's very happy to tell us about themselves on a phone. So it opens up, like, the synergy of these two things is really very exciting in terms of clinical care. So a few years ago, in my previous hospital at Sloan Kettering, we were opening a new hospital, an ambulatory surgery hospital that was a 23-hour stay. And in designing this, they really wanted to be very patient-centered. And so at that time we had something called the PROS Center at the MSK, and so we were really keen to get involved and make this kind of the flagship of patient-reported outcome measurement within Sloan Kettering. And they also were very open to us innovating. So what we did is we put patient-reported outcome measurement all the way through the patient journey. And I'll just show you an example of what we did, particularly around recovery after ambulatory surgery. So at this new hospital, we are doing quite major surgeries like bilateral mastectomy surgery, prostatectomies, surgeries that you used to stay in hospital for a couple of days, or maybe it used to be even longer, a few days, and even longer than that. Now patients are going home pretty soon, maybe at 23 hours, and it's actually a big deal to transfer them to the main hospital. So that's good in many ways, certainly good in terms of cost. And for patients, it also can be very good to be sleeping in your own bed. But it also does put an additional burden on patients and their families to walk out the door with all your drains and your medications, and you're a little foggy, and your husband or wife is a little anxious. And so we're thinking about how could we use patient-reported outcome measurement to actually to make that process just a little bit easier. I'll just digress to tell you a story. The thing that crystallized for me is I had a patient that was really lovely, 33 or 34-year-old pediatrician, and was having bilateral mastectomies for kind of a small breast cancer, and she was coping beautifully through the whole thing, like smart woman, taking it in stride, very supportive family. And I went to see her at Josie, actually, as we were started setting this whole program up. I saw her the morning after surgery, and she just sobbing, very upset, and I said, what happened, or is there something? And she just said, I don't know if I can go home. I don't know, how will I know if something's going wrong? This anxiety. And here's a woman who's a physician and also very supportive. So you imagine then, take my elderly Hispanic woman, take my patients that are not in a very good social situation. And so we really thought about what can we do to make that so that essentially when people step out of the ambulatory hospital, that they are actually feeling that we've still got them, that that the virtual hospital extends to home for them as well, that someone's still keeping an eye on them. And the other thing I would just say is, and this is work from one of my colleagues at Memorial, Ethan Bosch, who's a medical oncologist, but just to point out is that he did some work, a number of years in ongoing work, looking at how patients perceive symptoms and we perceive symptoms. And in the medical oncology world, it's very well known that as clinicians, we underestimate symptom burden. So, if I look at you, you're in the emergency room and I'm looking at you laying on the bed, I might rate your pain as a 10 and you might rate it as an 8. So to be aware that we also just don't really know what patients are feeling when they go home. And if we did guess at it, we might guess low in terms of the symptom burden. So what we did is we set up a system electronically with 11 symptoms that previously validated questions about sort of the 11 symptoms that most patients would be experiencing, like nausea, pain, fever, shortness of breath, those kinds of standard post-operative things. And we set it up so patients could answer these daily on their phone. It took about 2 minutes. We were able through the system to be able to see that it was, on average, that was taking less than 2 minutes for patients to complete it. And then what that would do is it would generate, patients were told about the system preoperatively, and they would be told also they would generate alerts to the nurses of that clinical team that if a patient was, say, reporting severe pain, we set different thresholds. So, severe pain on day 4, that would generate alert to the nurses, and they would reach out and make a phone call. And so that would give patients a sense that there was somebody still. So for the 10 days after surgery, it was like check-in. Think about the old days where the doctor would come around every morning to check on you, and the nurses came in every 4 hours. That's not quite that, but it's the idea of someone asking you how you're doing, and you're reporting it, and they're keeping an eye on it. So we did that. We actually very quickly got thousands of assessments because patients were actually really keen to do this. They felt that it sent a good message. They basically said, okay, I feel a little bit better leaving the hospital. But then we asked ourselves, what could we do a bit more with this? What would be the next logical step? And so what we wondered, and this is work I did with my colleague, Dr. Larissa Temple, who's chief of colorectal surgery now at Rochester. She and I both kind of quite recently left Memorial, sadly, but we both love the place. But So we asked ourselves, what could we do to make it, to essentially maybe give patients a little more autonomy, to sort of not be just sitting there waiting for the phone to ring. And because that was the feedback. We did a lot of qualitative work with patients to sort of figure out what they wanted, and they loved the system, but then it was like, okay, I just submitted my symptoms, is the phone going to ring, and when is it going to ring? And so we thought, well, what if we could give them some information to contextualize what they were feeling? And so we generated, so essentially based on the thousands of data points that we had received from the first round of patients that were giving us their 11 symptoms daily for 10 days, we were able to kind of come up with some normative data. And what we did is we started to generate reports that patients could, once you finished your 11 symptoms, up would pop a report that would tell you kind of how you're doing. It contextualized so that you would understand it. So this would be, so this is pain. This is day 4, and so it's understanding your symptoms, and it's moderate pain. 4 days after surgery is expected and nothing to be concerned about. But this is kind of the graphic that I actually think and patients like the most as well, is that what we did is, so this is our patient on day 4, and this curve is generated based on the data from the previous patients that had all been telling us about their experience over 10 days. So essentially what we're doing is helping patients understand this is the normal trajectory and how you're doing relative to other patients that have also had bilateral mastectomies or prostate surgery. But what's kind of interesting is that patients, when we were talking to focus groups about this and what we wanted, how to describe, we said, you know, you're better than other patients. What they didn't want, or like, what they wanted was the word expected, because they thought that we knew this curve, like that I could draw it myself. And so as the doctor, it's just interesting, the patients, they couldn't connect that it was like that we had to get it from other patients to have that curve in there. And they also didn't want to be compared to other patients, but they wanted to be reassured that we, the clinical team, thought that this was the expected term, this is the expected curve, and this is how they're doing. And so we also did things, so this would be also part of the pop-up. So this is a patient that's actually being told to call us. So this patient does have nausea, but more moderate shortness of breath. And so if he or she would click on that, they would get the pop-up that would say, you know, this is not normal on day 4 after surgery, and you should give us a call. Because the other thing we learned from talking to patients is that, you know, as much as we think that patients are calling us all the time, and anybody who's on call late at night thinks that they're calling all the time, patients actually don't, the majority of patients don't want to call us because they feel that they're bothering us, and they feel that and so they almost need permission or to be told to give us a call. So that was sort of surprising to me actually as well. And just to kind of, like, as I say, we did a lot of qualitative work with this, and what we heard before we started the whole system is we heard things like, I was worried about everything, looking for problems. This would be my pediatrician, sort of like is something going wrong, and how will I know? You know, it hurts at the drain site. Could that be a hematoma? I don't know. So that anxiety of not knowing. And then when we started with with just the phone calls, then patients started telling us, I felt more connected and cared for a longer time period. Like I didn't walk out the door and I was on my own. So that was reassuring. And then once we started the feedback, what we heard was this: I felt more in control, like I didn't just have to wait and wonder if everything was okay. So that was essentially being able to give. And so this was, this idea and this system is something that Larissa Temple and I kind of worked into a grant, and this was it's a PCORI grant that we're currently completed, that's in process or progress. And so we've accrued about 550 patients of 1,700. But what we're doing is essentially randomizing patients to either get the enhanced feedback, so they get that report, or they get the phone call from the nurse, and figuring out what, from a patient perspective, is actually what they prefer. You can imagine that the enhanced feedback is actually much less resource intensive, because anybody can do it. It's all data. It's not sort of, it doesn't require a call, like a phone center and a nurse that's doing so that. And as part of this trial, some of the things we're looking at are things like, we call them our urgent care, because we didn't have an emergency department, but ED visits. So either patients that are the worried well, like, you know, your wife is having terrible pain, so you call the ambulance and you go, but she's actually fine. Or the opposite is where patients should have been calling us and should have been in touch, and that something has progressed, so detection of adverse events. But also things like patient anxiety, patient engagement, empowerment in their care, and also looking at family and caregiver burden, because this is not a small piece of it in terms of patients, what they're like, say, you know, what it's like to have, you know, a loved one at home after major surgery for the week or so afterwards, and does the system potentially help? So that's some of the stuff about clinical care. We talked a little bit briefly about quality. I think, you know, it's pretty intuitive in terms of quality, is that listening to patients, has the potential to improve care. I think in terms of, this issue, it's thinking about figuring out what matters most to patients. That's the listening to patients and then focusing our efforts on those things that matter most to patients. I would also, the other point I'd make is just when we think about how patient-reported outcomes fit into outcome measurement overall, it's not that patient-reported outcome measures are replacing everything. So it's not that I think that we should not be doing M&M rounds or that we should not be looking at mortality or we should not be looking at our complications. But what we want is the best combination of both. So here on this axis, if you think this is the patient report, this is quality of life. This is high quality of life, but no minimal morbidity, doing well from your disease perspective. So even if the object of the exercise, if the whole operation was geared to improve quality of life, yep, but you want to get there without a complication. Or if the object of the exercise was to cure cancer, great, but you want to do that with the minimal morbidity in terms of patient-reported quality of life. So really where we want to be is here in terms of our quality improvement efforts. And just as an example, this is work from Memorial in urology. So this is patient-reported and clinicians, so PRO and CROs, looking at prostatectomy surgery. Here is the quality of life piece of it. This is erectile function and urinary continence. And here is disease recurrence, essentially disease-free survival. And so that's the green circle. What we want is patients that are getting a good cancer operation, but at the same time with the minimal morbidity. That obviously needs to be an adjusted analysis. There's lots of things that go into that. It's not the easiest thing in the world to pull off, but it is, I think, where quality is going, is understanding both the patient and the clinician perception of the outcomes data. Just moving a little bit away from the actual clinical outcomes, more about patient experience as an example. This also goes back to the new ambulatory hospital that we opened at Memorial. So we opened this new hospital, and Larissa Temple and I are figuring out, okay, we're going to do something around symptoms, and we're going to do something with quality of life, and we're going to also look at experience. So we decided that everybody going to this new hospital would complete the SCAPS. The SCAPS is a patient experience measure that was developed by the American College of Surgeons. So we put that in so that everybody was asked to do the SCAPS, and we ran it for a while, and very quickly got about 1,500 patients. And so here's what we looked at, and so this was actually very alarming. So this was sort of a quarter of patients were not satisfied with surgeon attentiveness on day of surgery. And this was, yeah, I know, but this was meant to be this hospital that was the best place to be. It was supposed to be so, we were, and also so Memorial surgeons are sort of, it's a really good group of surgeons. People really do care. It's not, and so it was like this, what? So we looked a little bit deeper at the data, and so here's, and furthermore, it's and who was measuring that, by the way? So surgeon attendance, so what it really came down, this is what people were telling us, the actual questions was discussion about the outcome of the surgery and visit of the surgeon before the surgery. So basically what patients were saying is they weren't seeing their surgeon before surgery consistently, and they weren't having that conversation they were expecting to have with their surgeon after surgery. Well, hello, it's an ambulatory hospital that's super efficient. And so we were up there operating and moving things through, and compared to our main hospital, which is 4 blocks north, where there's lots of time between cases and the patients are sitting around, then they go up to the ward and you go and you see everybody at the end of the day. That wasn't happening anymore. So what it was is the system had become so efficient, but not as effective as we thought it should as patients. And so patients were telling us, yep, you've created this thing where we're in and we're out, but we're not, something that actually is very important to us is not happening. And so we took that information back to the Department of Surgery. We shared it with surgeons so they could be aware of it, but also recognizing that the SCAP scores of these same surgeons was fine at the main hospital. It was in the ambulatory hospital the problem was happening. So it wasn't even so much the surgeons, it was the system. So then we were able to change the system to make it easier for surgeons to connect with patients both before and after surgery. We're holding them and saying, if you'd like to see your doctor, we'll give them a quick call. They'll come down. We actually did things with iPads so that even if the surgeon was in the OR, they could bring it in and they could actually see the surgeon's face, that kind of thing. So that wouldn't negatively influence efficiency. So just another example. I would just say, in all of this quality talk, I think it's important to think about the best quality measures are also ones that we're using in clinical care. So if we think about sort of how do we, assessing patient-reported outcomes, evaluating quality, and that cycle, I think the best, the most meaningful examples are when it's something that we're using in clinical care. And so, so as an example would that be, so we use the breast, a lot of centers use the BreastQ in routine clinical care. It's very big in Europe and the UK, much more so than in North America, I think, actually. And so clinicians, say, in the UK are actually very familiar with the BreastQ because they do use it. And so a number of years ago, the National Health Service in the UK performed an audit of breast surgery outcomes across the whole of the UK. They had about 8,000 patients that completed the BreastQ 3 and 18 months after surgery, and they had 85% response rate, so very robust data. And what they did is they made all that data publicly available. I'm just going to show you, and they also did some very significant quality improvement efforts around that. So I'm going to walk you through what this graph is. So this is what's called a funnel plot. And this is satisfaction with breast. That's that 0 and 100 number, where higher numbers. So this is the patient. Up here means you're very satisfied with how you look naked. And each of these dots is a surgical unit in the United Kingdom. So in the actual reports, you could actually figure out which dot was your surgeon. This would be the mean score for satisfaction with breast across the whole of the UK in an adjusted analysis. And these curves are the confidence intervals. So 1 standard deviation, 2 standard deviations out from, and the tail. Provider volume is not, this is not a provider outcome or curve. It's more about, this is the confidence interval. So basically saying, if we only have like 10 assessments, we're not so confident that that's really what your performance is about. Whereas if we have 150, we're very confident that's really how you're performing with your patients. So they were able to look at this and be able to sort of look at sort of the high-performing units and units that were not performing so well, and what were the drivers there. They did it for satisfaction breast and a number of the other BreastQ scales, and so this is an example of satisfaction information. And here, so look here, so these are groups that are less, they're below 2 standard deviations below their peers on satisfaction information. And so this is really poor performance, but it's a very fixable thing, which is actually what they did in the UK, is they identified these units, and they were able to share with them what these guys were doing in terms of their printed materials and their approach to patient education, and then be able to bring these low performing units up. What's also, and this is kind of going back to the psychometric stuff, so because of this ruler, this rash ruler that we talked about, and the fact that these items are essentially notches on the ruler, if I go back here, so this is, the mean score for satisfaction with information in the UK is 72. So 72 actually, if you do all these things, you get a 72, meaning you're talking to your patients about complications, you're talking to them about options, but you're not talking to them about how much pain you're not talking about some of the patient-reported outcomes like pain, about recovery, and what they could expect to look like and feel like after surgery. So it also allows us to really say in words, what does it take to move from a 72 higher? And it also basically it means that if you're getting a 30, if you're like one of those units that was way down there, you're not even talking about complications. So it's not just numbers, it's actually numbers that have words associated with them that have meaning. I think we're going to see more and more of this. It is very big in Europe, but it's definitely coming here. NQF and CMS are definitely moving into this world of so we have the patient-reported outcomes. We have PROMs, which would be like an example of the BreastQ, and then these PROPMs, or performance measures, and so that's essentially what you'll be seeing more and more of. An example would be, so BreastQ satisfaction with information is a CMS-approved quality metric, performance metric, and what it is we took satisfaction information, and we looked at the benchmark data in a large, I'll show you the trial in the US, satisfaction information. We went a standard deviation below that and set a benchmark. And that's really what, so PROPMs are about, so specifying the outcome, and so it's average change % improvement or meeting a benchmark. And so now BreastQ satisfaction information, we have a benchmark that CMS has agreed with, and that you can tick the box on your performance metric by reporting satisfaction information among your patients. One of the challenges, I think, though, in terms of sort of our performance measures, that this is something that's just happening, it's new, but we don't have very many, we have very few patient-reported quality performance metrics, and so what we'll be seeing is more and more of that, both the measures being developed and then also being put into use. This is the American College of Surgeons has been very proactive in this. This is, so within the ACS registries, and again, this is Larissa and I have been working together with Cliff Co. And team on this, and so putting patient-reported outcomes into to NISQIP. The principals of here have been working to have a very highly sophisticated electronic platform, psychometrically well-calibrated measures, but actionable improvement. And minimizing patient burden. So here's what we've done. This is just a quick look at what this is very preliminary experience, but what we did within the NISQIP platform is we introduced initially, to start off with, just really kind of a proof of concept, is we started with NISQIP measuring patient experience, a symptom, we picked pain, and overall quality of life. We took the PROMIS Global 10 just to see if really could we even do this with patients in NISQIP actually answer it. But where we want to get to is here is the condition specific. But that's a little more sophisticated in terms of figuring out which patient should be answering which questionnaire. Anyway, we just started this in October. So this is just October to March. So I just did a data pull this last week. So in 6 months, we've had 1,400 patients that have completed these 3 patient-reported outcome measures. And interestingly, so we have sort of geographic representation. What's interesting is once patients, so the average time to completion of these 3 measures is 6.4. We're seeing that median age is actually 62, so we're not seeing that patients that elderly patients, that was a concern that elderly patients wouldn't complete the questionnaire because they wouldn't be comfortable with it. So we're seeing that elderly patients are engaging with this, and that once patients start doing it, their response rate is very high. They get through the whole thing. And this is actually more than this is 3 questionnaires. What we'd actually like to do is target it to make it even a little less burdensome. So this is a preliminary experience, but we are now rolling it into condition specific, and then we'll kind of see where it goes from there. So value. So lots we could talk about for value. I'm going to be brief, but just, clearly healthcare costs are rising. The traditional value equation is this. So value is outcomes over cost. And I think increasingly what we're thinking now is that where do PROs fit on that outcome? So we could put it together, PROs and CROs. Doesn't make for such a nice slide, but it is the idea is that I think you're increasingly going to see that, particularly for operations where the object of the exercise, the whole reason you're going to the OR is to improve quality of life and improve patient-reported outcomes, this is the equation that our hospitals and our payers are going to be thinking about. And I think we've seen other examples of that. So this, again, going back to the UK, this is very much what they've done. There's a number of procedures, hip, knee replacement, varicose vein, groin hernia repair, where they've been tracking patient-reported outcomes relative to cost, and that's the value equation that they've been putting together. It's actually mandatory in the UK to have your patients, if you're, say, a hip replacement surgeon, you have to have your patients completing a patient-reported outcome measure before and after surgery. It's just mandated in order to get paid for the operation. The other thing that's interesting is around transparency of this data. And so this will alarm people here, but that's okay. So single payer system, they can do this. And I'm Canadian, so I kind of agree with it. But it has to be handled carefully. But so these are, again, these conditions. So this would be like your hip and knee replacement. There we go, varicose vein. So hip, knee, varicose vein, groin repair. So I just started, this is a screenshot from the UK NHS website. So I just started with the A's, right? And so here is, so if you were having your, let's say here, so down here, if you were having your knee done, you would and you were somewhere near Northumberland. Ainwick is really a great place to go from a PRO perspective, but you wouldn't want to be at Aintree Hospital because their PROs are below average, and so people can actually toggle through and figure it out. So that's another conversation another time, is how all this information is going to get handled. But there is more and more of this. I think our U.S. payers are very interested in this information. It's just an example. So in Michigan, the Michigan Bariatric Surgery Collaborative, and so they're using, one of our other measures is the BreastQ for bariatric patients, and also follows them through body contouring like paniculectomies. And so they've collected thousands of BreastQs in this patient population. But what the important point of this slide is just that this whole collaborative is funded by Blue Cross Blue Shield. So clearly and that's, the patient-reported outcomes is not the only thing the Michigan group is looking at, but it's increasingly important to their efforts. Finally, comparative effectiveness. So I'm just going to give you an example of one study. This is a study that I did in collaboration with my co-PI, Ed Wilkins at University of Michigan, and this was published in the spring in JCO. So this is just an example. You could think of other clinical areas, but we were looking at outcomes in breast reconstruction. And what the question was is, how do we compare the effectiveness of different types of breast reconstruction? And what we did is we had a multi-site consortium. We had 11 sites, 57 surgeons, and it was an R01-funded study. And we looked basically at preoperative BreastQ and then followed patients out for 2 years. This is our sample. We had of 2,400 patients that were eligible, about 1,700. Eligible meaning eligible and completed a preoperative assessment, a PRO assessment. 1,700 completed their one-year survey, and at 2 years we were able to have about 1,200 patients. 2/3 of our patients had implant reconstruction, 1/3 had flaps. And then, so just I'm going to, in the interest of time, I'm going to go straight to the findings. So what we found is that among patients, so patients who received implant reconstruction, in comparison to patients who had implant reconstruction, patients who had autologous or flap reconstruction reported greater satisfaction with their breasts, 1 and 2 year differences. So an 8.2 difference at 2 years out on BreastQ satisfaction with breast, a 6.1 difference in sexual well-being, 3.1 psychosocial well-being, and physical well-being, a 2-point span. So, and what we call that is kind of essentially, this is closest to the construct, or that this is closest to the issue of breast reconstruction, and these are things that have become more distant from the construct of interest, which would be sort of, so there's other things essentially that affect your psychosocial well-being than just your breast, and that's what this is, hence we see the diminution in the difference. This was a big study, so so it's relatively easy to get p-values. So the other thing we need to think about is the magnitude of the difference. And so just to give you kind of a sense of this is some of the you can think about minimally important differences, and there's other ways to think about clinical effectiveness, or clinical impact. But so just an example, so psychosocial and physical well-being, it was a relatively small difference between implants and flaps. Sexual well-being was a moderate difference, and then we had 8.2 at 2 years out for implants versus flaps. In terms of the superiority of the outcomes. This doesn't in any way mean that patients should, that all patients should have flaps. I do probably 50-50 in my own practice. It's more just the idea that we can share this information with patients, and we can also share it with our hospital. So at Memorial, we used to be kind of a 90% implants, 10% flaps, and we have changed dramatically based on this data and other PRO data that's been coming in from other centers showing the superiority of autologous reconstruction from a breast perspective. Later this afternoon I'll talk about the abdominal morbidity that can sometimes go along with flaps. But it's all information it's good information to help us make better decisions, identify our unmet needs, but also help our patients make better decisions when they're trying to figure out what procedure they might want to have. Just one other example of a clinical question. So this is from urology, and I point that this is a lot of this PRO data is stuff that we can actually, and I'll show some more this afternoon, but things that are clinical questions that we get asked often by patients. So among my urology colleagues, the question is, you've had your prostatectomy surgery, you're 1 year out, are things going to get any better? And here what they did is they actually used, so at MSK in urology, they do the same thing we do in breast, where they collect PRO data routinely as part of clinical care. So they looked at 3,000 patients that had submitted data as routine clinical care, and they were able to generate, they were to do this analysis that did show that urinary function and erectile function did improve over time beyond 1 year. So so harvesting the data that was collected in clinical care to feed essentially the comparative effectiveness analysis. And that's kind of where I see all this is going, is that we've broken it down into 3 different spheres, but in the center of it is we collect data from our patients about how they think and feel about the results of our treatment, and that data can get used in lots of different ways, whether it's for clinical care, quality, value, or comparative effectiveness. But what I think you're going to see coming forth is that there's going to be massive amounts of this data, because we're realizing that patients are very happy to give us this information, particularly when it's improving their care in some way. And that's exactly what we're seeing. So in our own experience at Memorial, we have about 50,000 BreastQs. And so where I think that's also going is going to be in predictive algorithms and being able to sort of start to understand, kind of helping even more, with more accuracy, predict, anticipate quality of life outcomes and satisfaction. So, just to wrap up, essentially thinking about how can PROs help us. So it's improving individual patient care. I think it's about quality, about value, and then the part that that I think, stay tuned for this, but I think it's going to be about prediction and how big data can be used to predict, and then also how prediction bringing both clinician-reported and PRO outcomes together. I'm going to end here. I'm going to with this quote from Bill Gates. I've been struck again and again by how important measurement is to improving the human condition. I appreciate your attention. I'd be happy to take questions.